coordinator here at WASP, and I'll be moderating our first session. In this session, the theme is surrounding mental health, medical and health education. We have Dr. Sara Beleil, who is a consultant psychiatrist and academic secretary in the UK's branch of Sudan Doctors Union. And then we have Professor Ibrahim Bani from Emory University. And we then will finish with Dr. Wadil Bashari from University of Cambridge. First, we're going to hear all the speakers and then leave all the questions to the end. So if you're ready to begin. Yeah.
Assalamu alaikum. أول حاجة I'd like to thank Professor Allam for the invitation to Sudan Knowledge Conference. I'm really pleased and honored. As the introduction said, my name is Sara Beleil. I'm a consultant psychiatrist here in the UK. I'm also the academic secretary for the Sudan Doctors Union UK branch here in the UK. I was invited to talk about mental health. So it's an overview about mental health in Sudan, what's been happening, past, present, and our hopes for the future. My topic, surviving to thriving. So first and foremost, أحب أترحم على الشهداء. على شهداء الثورة. I would like to pay tribute to the martyrs of the revolution, to their sacrifice, commitment, bravery, and heroism. I would also like to pay homage to the youth of Sudan, to the doctors in Sudan who have been at the forefront of this revolution, and to all the Sudanese professionals, including lawyers, teachers, engineers, journalists, name it, everyone, for their bravery and courage. I thought first to talk about, I'm trying to have a full overview about the past history in developments in mental health in Sudan, but the present, what's going on, and our hopes for the future. So my outline of the talk is going to be the developments over the last decade, 10 years, the challenges and priorities that we've had, the current situation that you're all aware of as of the 3rd of June, and then issues about surviving and then thriving. You can't talk about mental health in Sudan without talking about the father of African psychiatry, Professor Tigani al-Mahi. He is the first psychiatrist, I would say, in Sudan and the whole of Africa. He finished his training here in the UK in 1949 and established the first psychiatric clinic in Sudan in the 1950s. At the time, it was called the Clinic for Nervous Disorders. He was also WHO regional advisor between 1959 to 1964 and remained as the chair for psychiatric medicine at the University of Khartoum until his death in 1970. Talking about sort of developing psychiatry services, psychiatry is generally known as a Cinderella of medicine. It's unfortunately stigmatized not only by patients but also by professionals. So it's not been easy to have many psychiatrists to develop the field and to address mental health issues in Sudan. So the first and foremost challenge that we had to address was building capacity. Sudan population is around 42 million, distributed over 18 states and covering a total area of 1.9 million square kilometers. The majority of the population in Sudan is below 25 years of age. 0 to 14 years constitute the 48% of the population, and those between 15 and 24 represent 20% of the population. As you all know, Sudan's health profile is among the lowest worldwide. It's number 454 out of 160. So a real challenge, the issue about building capacity. And to build capacity, we had to look at education, basically, education and training. So what we did, we collaborated with colleagues in Sudan. So the Sudanese psychiatrists here based in the UK is a huge number of psychiatrists. We're over, I think, 100 psychiatrists based here. And we started working with colleagues in Sudan since 2011. Since then, we've had yearly annual conferences and workshops looking to training psychiatry doctors in Sudan, but also looking to support psychologist training, social workers, mental health nursing, and medical students in a way to attract people into the field of psychiatry, but also to start developing a workforce that can sort of address mental health issues all across the country. As I said, started in 2011, we had 40 participants. Last year, we had 250 participants. So a growing field, people are really interested in psychiatry. And it's always amazing when we go back there. It's like a pilgrimage every year. Most psychiatrists here, but also from the States, from the UAE, from Saudi, we all go back to Khartoum and we have these conferences. And the uptake by not only the doctors, medical students, but also the nurses, social workers, psychologists has been really amazing and gratifying. I would say we started thinking about how do we sustain the developments we've made so far, and based on this conference here, I felt it's important to address certain issues about this. So it is very much about the Sustainable Development Goal number 3. It's about good health and well-being. You can't have good health and well-being without mental health well-being. Talking about quality and education, as I mentioned, number 4, but also about reducing the inequalities. So that's about the building capacity to not only have mental health services in Khartoum, but also across the whole of Sudan. And then we started sort of to broaden a bit. We needed to start thinking about peace and justice and strong institutions as regards mental health. And addressing that, we had to really think about what are the challenges, what are the obstacles in developing mental health further. I've put here a few. That's not sort of everything, but I felt these were main issues that we've been working on in the last few years. One was the mental health awareness and stigma. Mental health stigma is a major obstacle to progressing and developing mental health in Sudan. That's very much linked to the spirituality and traditional healers issue. I'd like to mention something briefly here about spirituality. Sudan is a very religious country. And spirituality and religion are very intertwined in the Sudanese culture. We do look to religion to provide solace and comfort and reassurance at times of health and also at times of illness. So it's not surprising that we do seek support from religious and traditional healers. Unfortunately, that has at times been really, how would I say this, quite challenging. There has been a growth of traditional healers. Some are religious, some are supportive in a sense of providing solace and comfort, but others have used it more as a financial revenue. Every year we go, there's a rise in the number of these traditional healer clinics, and with sort of very bad practices, I have to say, which have been a major challenge. These include lashing of patients, including starvation. It's very much an exercise of exorcism that happened here before the church used to do that. So it's very much about pushing out the demon, the assumption that mental illness is very much a demonic or satanic infliction on the person. So by making the host unattractive, the idea is that you get the patient better. But that involves, like I said, lashings, tying up, starvation, and recently worse practices, really choking as well, where we've lost quite a few people through these practices. So that's, again, something that we needed to engage with traditional healers, and how do we support people, how do we raise awareness about mental health. The other development priorities we had were the legal system. There are lots of issues with the legal system in psychiatry. Many of you know about Masahat Kobar, which is a great institution. Saying that, there's lots of issues. It is, in a way, linking mental illness to criminality, which is unfortunate. And that's especially sort of uncomfortable when you think about people with depression, people with suicidal ideas. Suicide is illegal, and you would see definitely it being an obstacle to go and talk to a psychiatrist talking about your suicidal thoughts if you're worried that you may sort of face prison because of that. And again, it's an issue about knowledge. How do we know how many people are sort of committing suicide? Across the world, 1 million people commit suicide on a daily basis. So it's really important that we know numbers if we're to address any preventative strategies. Other issues about the legal system is the Mental Health Act. That was first drafted in 1997 in Sudan, and we've been campaigning for this since 2013. Mental Health Act is very much about respecting patients' rights. People, when they're unwell with mental illness and family brings them to hospital, or if they've done something wrong while they were unwell and they ended up being in the forensic system, they don't get any opportunities to appeal. If they get better, there's just no way of getting out. Like someone who's committed a crime would have a prison sentence, it finishes and they're out. With mental illness, even with treatment, people have no rights. So it's very much about how do we get a mental health act, something that's lawful, where someone to be detained under a mental health act into an institution is respected by law. They have a period of time, they can appeal, the system of tribunals. And we've been working actively, Sudanese psychiatrists here in the UK, as well as across the board, really, in United Arab Emirates, Dr. Zanamara has been actively working on this, and colleagues in Sudan. Unfortunately, like I said, even till last year, the approval was blocked at the last stage, really, reaching the Ministry of Health. It just didn't happen. While all this is going on, as I said, these were annual conferences that we went to in Sudan, and the idea was about how do we develop mental health services. But during this time, the country wasn't static. This was a time when people were there was that uprising happening, and people were in Sudan over the last year have been actively working towards a change across the board. And with the spirit of the uprising, we here at the Sudan Doctors Union held a conference, an international conference that was quite unique, and that was on the 6th and 7th of April of this year. It was unique in that it brought all Sudanese doctors across the globe together. So we got the Sudan Doctors Union from Ireland, from Canada, colleagues from the States, from the Gulf. We had colleagues from Sudan, not only doctors, we had psychologists, we had nurses, we had medical educators, all trying to come together to try and think about a new health system, about an alternative policy. We felt that change was coming, and the date says it all. 6th and 7th of April was the day of the sit-in. After months and months of protest, peaceful protest, that was the day when people did have the sit-in in front of the military headquarters. So it felt quite apt and the right time. And that conference, we managed to endorse the transitional plan, alternative health plan, addressing all health issues. And then that was taken forward with colleagues in the States, again, collating all the information and incorporating all colleagues, a collaborative effort to try and come up with an alternative plan once the revolution is successful and we have a new civilian government. The focus of the conference, as I said, was alternative health policy, and it was very much looking at what we need to do to bridge that gap of where we are now to where we should be. Thinking about a new health system for the 21st century. And it doesn't surprise any of you that there's a huge, not just a gap, it's a chasm, really, between where we are now and where we'd like Sudan to be. The guiding principles for these alternative health policies were very much based on health is a human right, it's an investment in human development, and not the mere absence of disease. That government had a key role in stewarding, in governing, and providing health. It had an obligatory role. It had to be pro-poor people, pro-gender, and responsive and equity-focused, and of course, evidence-based. We looked at dimensions of quality in that sort of alternative health policies, looking at accessibility, safety. The challenge in Sudan is the misdistribution of health services. So everything seems to be aggregating in Khartoum, in the capital, with hardly any services in the provinces. I'm talking about mental health here specifically. And that's unfortunate because we sort of started engaging with the primary care, primary health, preventative strategies way back in the 1970s. But more recently, in the last decades, it's become very much curative and reactive rather than any preventative work being done. And of course, there was suffering areas where the conflict zones of Darfur, Nuba Mountains, and the Blue Nile, where they've unfortunately been neglected for quite a few decades, really. I wouldn't just say years. This was a time when we were really quite actively working as health professionals across the whole sector. And it was very much within the spirit of the revolution, where we were thinking things were moving in Sudan. We were moving across here as well, and all over, making plans, what we would do, how we would sort of establish a new health system, how do we go about that, and feeling quite optimistic and positive about the revolution. By this time, it was a fully successful revolution, managing to topple the dictatorship of 30 years. And everything was quite optimistic and looking forward to a new time, really, to a new Sudan. Unfortunately, 3rd of June happened, the massacre, and I'll give you the latest figures we have from Sudan. We have confirmed 128 dead people, 42 reported rape assaults, of which we've got confirmation about 14. There have been suicide, there have been death as well, those reported rape assaults. And sadly, rape is a weapon of humiliation and torture. And I have to say, it's men and women. Over 700 people are injured, a few are still missing, and we have a whole country that's grieving. So after after all that optimism and hope and where we're going, we're suddenly faced with a new development, a massacre, unprecedented really in recent times, the number of death toll in one day in one place. And atrocities really, throwing bodies in the Nile. What was that all about? Injuring children, women, burning places. And you all know about how doctors have been targeted. They've suffered through, again, killing, being shot at, detained, and again, colleagues raped as well. Hospitals were locked. Patients weren't able to access care. Hospitals invaded by the militia Janjaweed. Atrocity, a real atrocity beyond anything that we could imagine. Which brings me to Maslow's hierarchy of needs. We were at a point where we were thinking about psychological needs and fulfillment at a time when we're thinking about further development. And suddenly we sort of spiraled down back to basic needs. We're now looking at security, safety, making sure that people are safe. And rather than thinking we're moving on with the plans that we had, we're now back to psychological first aid, trying to look into providing social and psychological support, looking to the needs of the individual, but also the family and the community, looking to support people to cope during this period of time of grief, and to try and avoid further mental health and psychological problems. And again, it's really difficult. Even psychological first aid without feeling safe is very difficult to do much with that, let alone to engage in further therapy. Just a brief idea about what that's all about. It's very much about listening, looking and listening to people and trying to link and make connections. And this is what our colleagues are doing in Sudan at the moment. It is a humanitarian crisis. It's a totally unacceptable violation of international human rights law, sort of looting of medical equipment, assaulting healthcare workers, and these are the people providing care. The mobile health clinics in the sit-in were burnt. People weren't allowed to access any help, and female workers, health workers, are particularly targeted even today. People are struggling, doctors, midwives, nurses, to provide care because of the not only the detention, killing, but also the rape assaults and the harassment that's going on at the moment. The WHO last week issued a statement. I'll just quote that, I'll just read that out. Unacceptable situation that has not only resulted in death and injuries, but also attacks against the very professionals and facilities meant to help. And they call for an immediate cessation of all activities that put the lives of health staff and patients at risk and disrupts the delivery of essential health services. It is a hard time, but I would like to sort of not leave it there. I would say that the spirit of the revolution is there. We are still very firm in the belief that we will get freedom, peace and justice. We are working towards a democracy, a civilian government, and we are sustaining that by the youth that we have who are leading this revolution. Sudanese people will get their democracy through the belief and the commitment and the resilience they've shown so far and the bravery and courage. I would like to pay tribute again to all people in Sudan who are working very hard to maintain that commitment and resilience, and applaud the courage and bravery. Thank you very much, and yeah, it's very much about raising awareness and keeping Sudan very much in the international agenda to try and bring pressure to the handing over from the Transitional Military Council to a civilian government. Thank you.
We're now going to open to any questions that anyone has. Yeah.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Sadiq Musa Ahmed, I'm from Multimedia University, Malaysia. A very good session. Just I have a question to Dr. Sara. Actually, in Sudan, we have very common mentality of exclusion. Mentality of exclusion among the Sudanese. الإخصاء عقلية الإخصاء يعني this is a very serious problem. All the problems that we are facing in Sudan because of this exclusion mentality of Sudanese personality in politics or everything, and this is contributed to non-collaboration. Sudanese are not collaborating in terms of research, in terms of anything that companies. Socially, they are very connected. But when it comes to business, they are very reluctant to share. Have you gone through any study to analyze this very dangerous mentality that is the main factor we are lagging behind?
Thank you for the question. I would actually disagree. I don't believe Sudanese people are يعني عندهم الإقصاء at all. يعني يمكن حاجة الحس إن إحنا يمكن الحاجة اللي كانت واضحة جدا.
Specifically in political aspect. Specifically in political aspect.
I will just say one simple example يعني قول الحرية والتغيير how exclusive is that ده أكتر حاجة لمت كمية من التيارات مع بعض under one heading يعني سودانيين من كل الأنحاء jacked together with a one aim أمسك تجمع المهنيين الunionists again so long as the goal is clear والvision is clear there is no exclusion هنا. المشكلة لما تكون الأجندز are different. هنا بتحصل المشاكل. لكن لما يكون common theme is about well-being, about better good, about vision that everyone can aggregate around. I don't see any people would be exclusive at all. يعني ما في زول حيكون excluding الثاني. المشكلة لما تكون القصة بتاعت إنه sharing in a pot لكن كل زول عنده أجندة مختلفة. الحاجة اللي يمكن نحن أنا بالنسبة لي كانت really يعني how do I say this? A pleasure to see إنه بالعكس الناس دي كلها aggregated around one common theme اللي هو يعني I would say اللي هو التشارتر حق الحرية والتغيير لأنه ideals والvision is clear وما في two can doubt it يعني دي الحتة اللي أنا بفتكر إنه أزل ما عايز يكون progressive ولا leading ل a change يمكن هو يحس بالإقصاء لكن everyone who actually wants a better Sudan wants a new Sudan wants a place where في freedom where these beautiful حاسة شفناهم اليوث حاسة شفناهم الطلبة ديل والدكاترة الصغار يعني Sudanese people deserve a better life they do يعني from every walk of life يعني they fought hard for it و they've been repressed for so long فيمكن الإقصاء يكون ل people who are not actually willing to join في movement towards a free Sudan, which is peaceful, which is progressive, which is 21st century Sudan. لكن I wouldn't say يعني في exclusion, so long as our people are sharing the same goal and vision.
There is no exclusion. Why until now we have this agreement to form transitional government?
طبعا أنا أتوقع حاجتي about mental health لكن still I will say I'll answer that being a unionist. المشكلة بتاعت الpower. People find it very hard to let go of power. People are fearful of reprisals. People are fearful of investigations. These have been 30 years of atrocities. يعني you think about the conflict zones, Darfur is a huge issue. And it needs to be opened up. جبال النوبة, النيل الأزرق, الخرطوم now. يعني everyone knows يعني أنت you leave a power seat, you are going to be put on the question seat يعني. The problem is we can't يعني ما ممكن الناس تنسى الحاجات اللي حصلت دي. It is not fair. يعني people have suffered, people have been oppressed for years and لازم يحصل يعني acknowledgement to resolution للحاجات الحاصلة عشان الناس تقدر to move forward. لكن so long as people are clear and keen on a better Sudan الناس تتغاضى عن الحاجات personal و to be able to see the bigger picture, I wouldn't say إنه a solution is not going to happen. I would very hope, يعني I'm very hopeful in a solution would happen and pretty soon hopefully.
I'm sorry if you give me a chance. Actually, I have very hard experience to dealing with Sudanese, especially in research and development, as a supervisor or a collaborator. Sudanese are very reluctant to share. Even the PhD student we supervise, they don't want the supervisor to share with them. And I have found this very common mentality. I'm talking from very serious. I have seen the problem actually. It's hard to supervise a student from Sudan. It's very hard.
يعني أنا ما بحب التعميم والgeneralization. أنا I contribute regularly للworkshops والconferences مع السودانيين السايكايتري specifically. لكن برضو as academic secretary في النقابة الأطباء فرعية إنجلترا, we do not see this. بالعكس we see a very collaborative spirit. يعني I wouldn't go far. Even this example, يعني my colleague here, the work they've done in Sudan. It's enough of an example. وما بس collaborating as Sudanese مع Sudanese, لكن even inviting other collaborators international to collaborate مع السودان. the Sudan of yesterday has moved, and السبيريت حقت اليوث اللي احنا شايفينها دي, the way they managed to conduct a sit-in, the city we saw, يعني we saw a glimmer of the Sudan that we all dream of في الفترة حقت الاعتصام دي. We could see the beauty حقت الكولابوريشن, السبيريت حقت الشاي بوين, الارت, الميوزك, التمثيل, الدريمز, التوكس. It's a different youth today than one maybe that يعني was there a long time ago, لأنه الحاجة اللي حصلت the youth that will not be stopped. It is forward thinking, it is quite civilized, it's quite progressive, it's brave and courageous, and يعني I wouldn't like to generalize an experience that you talk about. I hope I've answered the question.
Thank you very much. Actually, I want to get the best of your knowledge through this question. Please take it easy.
أحسن أقول بالعربي عشان كلنا الأودينس كده. معروف الإنسان اللي بيلجأ للانتحار هو بمر بظروف نفسية تعبانة جدا جدا، وصلته لمرحلة إنه ما في يعني فايدة من حياته. ففي السودان في كل دول العالم الإنسان اللي بيلجأ للانتحار ويفشل بيتعالج، لكن في السودان عندنا الإنسان اللي بيفشل في إنه to commit this suicidal he failed to access on this, so he will be targeted by الجفرمنت وبيحطوه في السجن. فأنتوا يعني دكاترة بريطانيين وعندكم حاجات، يعني عندكم القوة في إنكم تصلوا صوتكم للحكومة، عملتوا شنو في الحتة دي؟ شكرا جزيلا.
طيب شكرا على السؤال. طبعا يعني this is a very sensitive topic. وفيها شغل كتير يعني ماشي. طبعا المشكلة إنه الستيك هولدرز كتار في القصة حقت الليتيجيشن الليجل سيستم في قصة الانتحار سبيسيفيكلي. ففي يعني في كمية من الأطباء النفسيين شغالين كانوا مع الناس الحكومة، مع ناس الوزارة، مع ناس الأوقاف، عشان to try and يصلوا لحتة بتاعت إنه الأندرستاندينج behind الانتحار والسويسايداليتي. يعني بكل المقاييس قلتها أنت، يعني هو لو ما مات حيترمي في السجن، وحسها وتزمانش بينه الناس يعني الأطباء والحقل الطبي they will support هذول بينه ما تو يعني إنه ما يعني it is done أي treatment بتحصل ما بكون مثلا إنه they will involve البوليس وكده. لكن طبعا لو البوليس عارف حتكون مشكلة يعني. it is a real challenge يعني، لأنك أنت how to access care وsupport وأنت مثلا عندك severe depression والsuicidal thoughts are part of the symptoms حقت الإلنس. how to مثلا الناس اللي عندهم schizophrenia أو bipolar، يعني الأمراض النفسية الكثيرة دي واحدة من الميجر نحن يعني complications حقتها هو الانتحار. صعب تاخد لك preventative strategy وتعمل لك برنامج ل addressing suicide لمن هو يكون illegal. How do you even bring it into the conversation? How do you bring it and talk about it? طبعا يعني I would say كأطباء نفسيين it is very much part and parcel of التريتمنت حقتنا. الانفستيجيشن that we do كان هنا كان في السودان. في السودان طبعا يعني لما نمشي نعمل التريننج I have to say a psychologist, a psychiatrist يعني كلهم well trained into assessing the risk حقت suicide و implementing and supporting the patient into a management plan including the family و making sure إنه عندهم access للتريتمنت و pathways of care. لكن المشكلة طبعاً إنه how do you get people to reach that point إنه حتى يصلوك أنت كprofessional to start talking about it. But like I said, lots need to happen. لسه this is area of progress و development that we need to work at.
بنحلم بفضاء أوسع، بنحلم بزمن أجمل، بلاد ميلاد بلاد ميلاد